I'm in charge of our busy diagnostic clinic that most of you are familiar with. It's been running for a long time. It's changed slightly since COVID started, and right at the end of the talk, I'll give you a little bit more information of how to refer patients for you that's not familiar with the new way of doing it. And then, I do some private practice as well at the Ingress Breast Healthcare Unit, and we've got a multidisciplinary team there that look after patients with breast cancer and other breast complaints. So, why talk about benign breast conditions? I mean, whenever I've spoken at the UTT GP update conference once or twice on breast cancers, and when you go to the breaks and people come and speak to you, actually the questions that people ask is on benign breast conditions, and I think that's where most GPs actually see a lot more patients with benign conditions than with breast cancers. Obviously, with breast cancers is a thing that most patients are worried about when you see them, but most of them actually have benign pathology at the end of the day, and they don't have a breast cancer. So I think breast cancer benign breast conditions is a very important topic to talk about. And when you look at a GP practice, it can make up to 5% of consultations. And I think that's why I'm getting these questions. So what I'm going to talk about is mastalgia, which is probably the most common complaint that people come to GPs with, complaining about breast problems. Mastalgia is the number one. It is the number one in our clinic as well. And in some breast clinics, it can be up to 70% of patients that present with mastalgia. I'm going to talk about breast nodularity just quickly so that one doesn't forget that can harbor a important complaint that shouldn't be missed. Fibroadenomas are very, very common, especially in young women, and this is actually one of the things that lots of people ask me about. How do I manage these patients with fibroadenomas? I'm going to talk about breast cysts. I'm going to talk about nipple discharge, breast infection, and finish off with gynecomastia. So it's quite a lot to say, and I'm going to try and get through all of this in the shortest time possible. So, like Jason said just before I start, so if you've got any questions, you can drop them in the question and answer section. And Tertia, who works with me in the breast clinic and at Ingress Health, she will answer those questions if she can while I'm talking, so we can interact there. And then if you've got other topics, I think we want to try and continue these sort of general surgery lectures for GPs. And if you've got any other topics that you want to sort of us to present, I'll get Tertia to do the next one. So if there's any other general surgery topics, things that you want us to speak about, maybe just drop that in the Q&A as well, and it will give us some ideas of what to talk about the next time. So let's start about benign breast conditions then. So just, you need to know a little bit about the anatomy of the breast to understand what's going on. So essentially the breast consists of three main components. There's an epithelial, a stromal, and fat component. And the epithelial and stromal component is under hormonal control, where the fat component is not. So looking at it in a diagram like this, the purple will present the epithelial component, and that consists of the breast ducts, the milk ducts that transport the milks during lactation, and the lobules where the milk gets manufactured. So that's also the glandular component, and that's the main part that's under hormonal control. The stromal part of the breast is the sort of marked in pink on this picture, and that is what gives the breast its shape. It's in between the glandular part, and it holds everything together. It's the connective tissue in between the ducts, and that is also under hormonal control. And then in between that, there's fat. So patients that are overweight, they might have large breasts, and a lot of that is because they've got fat in their breasts, and if they lose weight, their breasts will get smaller. So the problem with benign breast conditions is that a lot of changes that happens in the breast is actually physiological, and there's a very, very fine line between physiological complaints that patients have and what is actually a pathological condition. So there is this sort of hell of an overlap between physiological and pathological conditions in the breast. And what one patient might experience as pathological, another patient will just accept as a physiological change. And often these are just physiological changes, and it's not really pathological. Where we see this often is with nipple discharges. So most nipple discharges are actually physiological and not necessarily pathological. So just starting with mastalgia. Mastalgia can be cyclical or non-cyclical. Is it really that important to know whether it's cyclical or non-cyclical? I think the only sort of information that it gives you, trying to distinguish between the two, is if you know that pain is cyclical, you know that it is hormonal in nature, and it is most common in patients that are premenopausal. Whereas a non-cyclical mastalgia might be something else. Often it is musculoskeletal pain or referred pain into the breast. So if you can distinguish between the two, then it does give you an idea of what might be the cause of the pain, which might help in the management. You also need to know whether the pain is focal or diffuse. So is the whole breast painful, or is there a specific area that the patient can actually put their finger on and say, listen, doctor, this is where my pain is. So obvious focal mastalgia would be more worrying than, say, for instance, diffuse mastalgia, which is often hormonal in nature. We know mastalgia is related to hormones. Oral contraceptive tablets, pregnancy might induce mastalgia. And then there's a large component of patients that actually have extra mammary pain. And when you examine a patient coming to you with mastalgia, I get them to lie on their sides, and I try and get the breast to drop out of the way, and I put a little bit of pressure on the breast and ask them, is that painful? Or try and press in behind the breast and see if it's actually coming from behind the breast rather than the breast tissue itself. A lot of patients refer to our clinic with mastalgia actually just have costochondritis. When you examine them, they've got quite clear tenderness over the costochondral joints, and it's actually not coming from their breasts at all. So some of the causes of non-cyclical mastalgia is cysts. So cysts would be often represent as a painful lump in the breast. Patients will come to you. They're usually slightly older, and when you examine them, you'll feel a lump. They're just slightly painful. It often is a cyst when you put an ultrasound on that breast. Periductal mastitis or any inflammatory condition of the breast. Stretching of Cooper's ligaments. So if the breast is swollen for whatever reason, the stretching can happen, and that can cause pain in the breast. Traumatic fat necrosis after often seatbelt injuries or just trauma to the breast, or Mondor's disease. Mondor's disease is a thrombophlebitis. It's very rare, but I've seen it a couple of times in the breast, where you can actually feel that sort of hard, inflamed, tender vein in the breast. So I think the main reason why people with mastalgia will come to the breast cancer is because they are worried that it's a cancer. I mean, this is why people go to doctors so quickly with anything wrong with their breasts, because, all of them have got a family member or someone that they know that have had breast cancer, because it is the most common cancer in females. Patients will go to their doctors for the slightest problem in their breast, and for good reason, and we don't discourage that. But it's this fear of possible cancer that fills up clinics and waiting rooms with patients with mastalgia. And actually, the rates of breast cancer in patients with mastalgia as the only symptom is very, very low. It can range from 0.2%. I've put 1.2% here from these two articles, but a lot of texts will quote up to 5%. Obviously, that range differs according to the age of the patients. So if your patients are older or they've got a family history of breast cancer, their rates of breast cancer is probably going to be closer to the 5% rate. And if you've got a younger patient with mastalgia, their rates are probably going to be closer to the 0.2% rate of breast cancer in that breast. So actually, the rates of breast cancer in patients presenting with mastalgia as the only symptom is extremely low. So is imaging indicated in patients with mastalgia? A mammogram and ultrasound we will do if a patient's older than 35 years. Sometimes we'll push that to 40 years of age, and usually when it is focal mastalgia. As I've said before, patients with more diffuse mastalgia is often hormonal in nature, and it's the chances of that being a breast cancer is extremely low. But if there is a focal point, or they can point to a certain position in the breast, especially if they're older, with that type of mastalgia, we would advise a mammogram. And at Groote Schuur at the moment, I've made an online booking system where a patient with focal mastalgia, older patients older than 40, can go straight from the community or from their GPs or clinics. They can go for a mammogram, and we will review those mammograms, check the results, and let patients know if there's any problems in their breast. So there's no real imaging indicated in patients under the age of 35 with normal examination, because the risk of breast cancer in this is so low. I mean, if you are going to do anything, a targeted ultrasound is all that's needed for patients with focal mastalgia. I mean, if you've got access to an ultrasound machine, you can put it on the breast. I mean, it's amazing the therapeutic value of an ultrasound. Patients won't believe you that there's nothing wrong with that breast until you've put the machine on their breast. So what I often do is I just put the ultrasound, which is in my clinic, I put it on the breast, I have a look around where the area of pain is, and you can see if there's something cooking there or not. So because we've got easy access to that, I mean, we often do that, but it is actually not really indicated. If you've got a normal examination in a young patient, you don't really need to do anything for that patient in terms of imaging. The treatment, I mean, the importance of reassurance cannot be overemphasized as the most common fear in women with breast pain is that of breast cancer. So, I mean, reassurance here is one of the main things. I mean, patients will come to the clinic, they're worried, and if you just reassure them and tell them, listen, the chances of there being a cancer is extremely, extremely low. Cancers don't present with pain as their only symptom. They present as a breast lump, as a breast thickening, as a bloody nipple discharge. You give them all the symptoms of how cancers present, and they would often walk out of the room smiling just because you've reassured them that there is no cancer and what is the symptoms that they need to look out for. I often show them how to do a self-breast examination, and that is all that they really want. They just want that reassurance. If the clinical examination rules out malignancy, the patient must be counseled that the possibility of having cancer that's undetected is extremely, extremely low. If you want to do something, if you feel that reassurance is not enough, you want to do something, or you want to make the patient feel that you're doing more for them, there is a couple of things that you can do. So pain chart is one of the things. I'll show you how that thing looks in a moment. I don't usually use it, but sometimes, you know, if you're not sure, or if you just want to, you've got a more anxious patients and you just want them to be a little bit involved in their treatment, because often breast pain, in a 6-month period, most breast pain will actually settle spontaneously without any treatment. So if you can just get the patient involved in their treatment, often it settles down on its own, and you know they'll get better. And a breast pain chart is one way to do that. We can advise them to stop smoking. There's no real association between breast pain and smoking that's been definitely proven, but you know, we usually do that. We also reduce the caffeine intake. Again, there's no clear evidence to show that really makes a difference. And then a good fitting bra might be indicated. Patients often have the wrong size bras. You can see the wire sort of digging into the side of their breast. Often that's the area that's painful. So make sure that they've got the right size bra, or send them to someone that can do a proper measurement and get the right size bra. Often we advise them to stay away, even if it is just for a little while, from the bras with the wires, and rather use a sports bra which they can wear for 24 hours of the day. Even at night, they must sleep in the bra for a week or two and see if that makes a difference in their breast pain. So this is what the pain chart looks like. So basically they just every day. So this is a 3-month chart. You can see every month has got a day, and on that day, on the first, they'll just put in whether they've got no pain, mild pain, or severe pain. And according to this, you can then see whether there's a cyclical nature to this pain, or it's just a constant pain there all along. It's also useful in some of the treatments later on, if you know if there's a certain time in the patient's cycle where they experience most of the pain. So it might be useful later on. So I sometimes give patients this, but it's not really my practice as a rule. So when it comes to management, pharmacological management, I mean, we'll usually start with non-steroidal anti-inflammatories and paracetamol. If one goes, and I haven't done a lot of, I haven't put a lot of slides in here about the evidence for and against and this and that. I mean, for academic talks that we usually do that, but I think this is more of a practical talk. But if you look at the evidence for the management of breast cancer, most of the evidence and the best evidence that we've got in randomized controlled trials, and you must remember in those randomized controlled trials, placebo had a 30% effect. So whether it's the placebo effect or whether it's just the breast pain that gets better naturally, we don't really know, and it's very difficult to read trials that was done on pain, because one patient's perception of pain is not the same as the next patient. So every patient experiences it differently, and it's very difficult to read these articles. But if you look at the best evidence that are out there for pharmacological treatment of breast pain, non-steroidals is the, over and again that shows to be the best thing. It is doesn't cost them a lot of money, and it's shown to be the best. So we will use oral non-steroidals. Obviously, it's got problems that you guys know well about. So topical non-steroidals like Voltaren gel is actually the preferred thing. And I usually give a patient just a private script, because we don't have that in the public sector, to go and get some Voltaren gel, or they can use the Transact patches. That will have more of a sustained release, and they can put a patch on and go on with their lives during the day. The patch will be there and it will release the non-steroidals, and according to the trials, 60 to 80% patients will have an effect with this, and it will be better than using something else or a placebo. So evening primrose oil is also, I mean, this is also in some of the trials, up to 70% of patients will have a response on evening primrose oil. Problem I've got with evening primrose oil, it's expensive. It often is, if one look at the trials, all the trials that have been done on evening primrose oil use 3 grams daily. That is 6 tablets a day. So when I started in the breast clinic, I used to say, okay, go to Pick n Pay, go and buy yourself some evening primrose oil, take a tablet a day. I used to explain to the patients that it's not going to work immediately. They need to drink it every day, at least for a month or two, before they really see whether it makes a difference. And then I went and I read all these trials using evening primrose oil, and all of them use 3 grams daily. So I was completely underdosing the patients. So they actually need to take 6 tablets a day. 2 tablets every 8 hours or 3 tablets every 12 hours is fine. But they need to use the 3 grams. That is what was used in the trial, so I don't think we should use less than that. The problem with that is it's quite expensive. I've looked at the cost of this 2 or 3 years ago. Pick n Pay, it will cost them between 240 and 300 Rand for a month's supply of evening primrose oil, 3 grams a day. So for public sector patients, that is a bit much. And I think for a lot of patients, if you give them tablets that cost 300 Rand a month, they often, say, "Ooh, these things are very, very expensive." So there is cost associated with evening primrose oil, and the trials actually, evidence not that great that it really makes a difference, but it's something you can try if the non-steroidals doesn't have the appropriate effect. So I would still say start with the non-steroidals. And like I've said, the evening primrose, you've got to take it every day. You're not going to have an immediate effect, and you need to continue it for at least a month or two before you say, okay, this is not working, I'm going to leave this. It apparently works. It makes the breast less sensitive to estrogen, and by that way helps for the pain. And then absolute last line of defense for someone with breast pain would be using tamoxifen. Tamoxifen is a SERM. It's a serum estrogen receptor modulator that we use for breast cancer. It's a treatment we use for premenopausal patients with estrogen receptor breast cancers. And it usually gets prescribed in a dose of 20 milligrams a day for breast cancer patients, but off-label, a lot of trials has been done on tamoxifen, and 10 milligrams a day for patients with nostalgia is actually supposedly very good. I've used it a couple of times on patients, and they don't want me to stop it. It has problems. First of all, you can't give it to a patient that's of childbearing age that are not on proper contraceptive tablets, because they can't fall pregnant while they're using tamoxifen. So that is one of the problems you've got with it. It's got side effects. At the lower dose, I don't know. I usually give them 20 milligrams a day at Groote Schuur, because we don't have the 10 milligram tablet available at Groote Schuur. So it will give them hot flashes and postmenopausal symptoms. And if they are going to be on it for a long time, you put them at risk of developing endometrial cancers and those things. But they shouldn't be on it for longer than 6 months, really, and you should try and wean them off it after that period of time and see whether you can stop it or not. You can go to once every 2 days. That's what I usually do, and I slowly try and wean it off and get the patients off. I mean, I've used it only a couple of times in the breast clinic. The patients I used it on was happy with it, but these were the patients that we've tried everything else and they are desperate and they come to me asking for mastectomies because they've got so much pain. And in those patients, I've tried tamoxifen and with some success. So it is something you can try. It's off-label. It's not licensed for mastalgia, but it gets used for that all over the world. So just a little flow diagram of basically what I've said is patient presents with breast pain, you perform a physical examination. If there's a mass, you order your normal imaging that you would do. If it's a young patient, they get an ultrasound. If it's an older patient, they usually get a mammogram and an ultrasound. And if it's something that needs a biopsy or needs a surgeon involved, you can send them there. If you don't feel a mass, if there's a normal examination, in young patients, possibly a targeted ultrasound if it's focal mastalgia, not for diffuse mastalgia. And if they are older, you can do a targeted ultrasound or mammography in that area, especially if they've got a family history or the patient. Often the patients know there's something not right in that breast. If you do find a mass, then obviously you need to follow the pathway of biopsy and treating that mass on its own merit. And if you don't find a mass, reassurance is the first treatment for mastalgia. After that, some of the supportive measures and then analgesics. And if you have tried all of those things and you have persistent pain, then I would say refer on, but you can sort of try the second line treatment, even in primrose oil and tamoxifen. Then breast nodularity. Again, the risk of malignancy is very low in someone with nodularity, especially if it's symmetrical. So I always teach the students that when you examine a breast and you're not sure that you feel something there, yes or no, you've got inbuilt control on the other side. So you go to the other breast, you examine that exact same spot, and you can even put your left hand on the patient's right breast and right hand on the left breast, and you can palpate those two areas simultaneously, and you can compare the two sides. So if you feel something, a nodularity on the one side, and it's not on the other side, then you sort of have to take it seriously. Again, in younger patients, especially if they certain times in the menstrual cycle, they can develop these nodularities, and you might just want to re-examine them, in a different time in their cycle, 2 or 3 weeks later. And best time to examine is about 7 days after the menstrual cycle started. That's when you don't have this much hormones around, and that will be the best time to examine them. And if it goes away, that's fine. If it doesn't, you might have to refer that patient if they've got this persistent nodularity in the breast. Asymmetrical nodularity they don't really need investigation unless it's persistent after re-examination. It is in an older patient, and in those patients, you really need to do a triple assessment and a full triple assessment. I mean, this is where people go wrong with lobular cancers. You feel something there, there's a nodularity, it's an older woman, she's 55, she says something is not right in my breast here. You send her for a mammogram comes back as normal. The lobular cancers you often miss on mammogram. You can have a completely normal mammogram and there's a lobular cancer sitting there. I've seen this again and again and again. Not once, not twice, a couple of times. And then eventually someone does a biopsy, and that's how you diagnose that lobular cancer. So a triple assessment means a biopsy, imaging, and an examination. So be careful of a normal mammogram in someone with nodularity. It actually needs a biopsy. Okay, so then fibroadenomas. Fibroadenoma basically is a biphasic tumor. It consists of those, if you think back to those 3 components in the breast, consists of an epithelial and a stromal component. And basically, those are the 2 components that's under hormonal control. So when a patient goes through their menstrual cycle, these fibroadenomas are often painful. And because it really is just a compacted area of normal breast tissue, they often complain of more pain in that area, and that's how they often feel the lump and go to the doctor with this little painful lump. But Overall, fibroadenomas are not really painful. They've got a peak onset of between 15 and 35. And we don't exactly know what causes them, but it most likely is a hormonal cause because they occur early in the onset during the premenopause. They grow during pregnancy or estrogen therapy, and they regress during the menopause. They're typical immobile lump, 2 to 3 centimeters, and then most of them will stop growing. I don't know why 3 centimeters, why 2 centimeters, why is a pea the size of a pea, why is a bean the size of a bean. That is, they usually grow to that size and then they stop growing. If you follow them up, 50% of them would be stable. They'll stay exactly the same size. 25% of them will grow and get bigger, and 25% of them will regress and slowly get smaller over time. I mean, if you leave them there long enough, most of them actually go away over time. They are well defined and they're smooth. It can be painful, but not. They're often not painful. And we've got a management approach at Groote Schuur that we have developed, trying to do it in a safe way. We don't miss cancers, but we also don't over-investigate and over-follow up patients with fibroadenomas. So what we basically do is we say in patients under 20 years, and this is why we don't really see patients under 20 years in our breast clinic, because we don't actually do anything for them. So under 20 years, if the clinical examination sort of fits in with a fibroadenoma, it is a mobile lump in the breast that feels like a fibroadenoma. We don't do anything. We don't ultrasound them. We don't biopsy them. So it's just a clinical examination. And we will take them out when they're large. When they're larger than 4 centimeters, they are called juvenile fibroadenomas or giant juvenile fibroadenomas. And those ones we would take out. We'll do a general anesthetic and take them out. When a patient is between 20 and 25 years of examination, I see lots of those patients. I usually see the younger patients because I do the ultrasound myself in the clinic. I've also got Tertia helping me with those ultrasounds, and I'll tell you about the breast clinic later, and she's probably going to do a lot of them on a Wednesday going forward. We do a clinical examination, we do an ultrasound. If that ultrasound looks like a typical fibroadenoma on ultrasound, they've got all the features of a fibroadenoma. They feel like a fibroadenoma, they look like a fibroadenoma. We are actually happy to tell those patients it is fine. We give them a little leaflet and we say, listen, you've got a fibroadenoma in your breast. Unless this thing rapidly increases in size, you don't need to do anything else for it. Some patients will push us and say they want this thing out because it's painful. We're not against it. We will take them out under local anesthetic. But as a rule, between 20 and 25, they will get an examination, they will get an ultrasound, and they will leave the clinic happy, most of them. If anything is atypical, either the ultrasound doesn't look like a typical fibroadenoma or it doesn't feel like a typical fibroadenoma, we will do a core biopsy to get histology. And again, we will take them out if they are big. If a patient is between 25 and 30 years of age, we do a full triple assessment. The triple assessment would be a clinical examination, an ultrasound of the breast, and we do histology. So we do all three of those things basically in their visit that they come to the breast clinic. And then we would offer them excision. If they want it out, we would take it out. We would usually drop them on one of our local lists and we will take it out for them. I'm not against in that age group to remove it if they want it out. I'll sometimes offer it to say, okay, we can take it out. And then some of them will. I think in that age group, one needs to be slightly more careful, and you might want to, if they don't take it out, you might want to examine that patient 6 months to 12 months later just to confirm that the fibroadenoma is stable. But if it is stable in that period of time, you can probably leave it alone. I mean, a lot of textbooks will say you have to follow them up for 2 years. I think if the patient's very young, you probably don't need to go that long. Size, if it's more than 4 centimeters in size or on patient request. If a patient's older than 30 years, we do a full triple assessment again. That will include a mammogram if the patient's older than 35. And we've got a rule in Groote Schuur that all palpable breast lumps will be removed in patients over 30. I mean, I've had a couple of patients where fibroadenomas was taken out in that age group and there was DCIS. I mean, the cancer risk with fibroadenomas is extremely low. It's something like 0.002%. So it's a very, very low risk. Fibroadenomas is not associated with cancer. There's no association between the two, but because it's normal breast tissue, you can develop a cancer in a fibroadenoma. It's possible, and I've seen it. So it can happen. So that's why when a fibroadenoma suddenly changes, one needs to take. It's been there for a long time, but suddenly it starts growing. You need to worry about that one. But we take all breast lumps out that we can feel. Patients over that. That's the safest thing to do. So just a quick overview of basically what I've said again. So all palpable, new palpable fibroadenomas in women aged 30 and over should be considered for excision, even if benign on triple testing, as the likelihood of a new lump being a cancer increases with age. And palpable fibroadenomas in women under 30 years, benign on triple testing can be managed either with surgical excision or regular clinical ultrasound review until it's stable. And if atypical on any part of this, you should actually go and take it out. That is for palpable lesions. For impalpable lesions, these are usually lesions detected. Patients come to you with nostalgia. You send them to a radiologist, they do a mammogram or they do an ultrasound, comes back that they found a fibroadenoma in that breast. They would usually give it when they see it the first time, they will give it a BI-RADS 3 grading, which means the patient needs follow-up in 6 months. They often do that. If that lesion is stable 6 months later, they will usually change it to a BI-RADS 2, which means it's a benign. They think it's benign. So BI-RADS 2, you don't really need to do anything about those ones. There's no consensus on the interval surveillance, but like I say, there will usually be an ultrasound about 6 months later. But there's actually no indication to excise impalpable lesions if the triple test is reassuring. So in older patients, we might still do a triple test on them. In the younger patients, if it really looks like a fibroadenoma, it is a little bit more difficult to biopsy these lesions. We might just follow them up. But we definitely don't go and take impalpable lesions out because, it's difficult to take impalpable lesions out. You need to use special techniques to remove these lesions. And then fibroadenomas more than 4 centimeter, that's usually a golf ball size, should be considered for excision. So in all the age groups, I've shown you that more than 4 centimeters we take out. And any lesion being followed with significantly increase in size. So if it's growing quickly, you need to worry about it. We've had a couple of patients, we send them, and then they come back and they've got cancers there. So if this thing grows, they need to come back and we need to look at it. Yeah, a triple negative breast cancer can sometimes be very, very sneaky, and they can sometimes look like a fibroadenoma. So you always need to warn the patient. Come back if it continues to grow. A fibroadenoma will not grow over a 3 or 4 month period. There's no ways. If it grows, it will grow slowly. So the next thing is breast cysts. So this is the best picture that I could get to sort of describe what a breast cyst actually is. If one looks at the milk ducts, the ductal structures in the breast, they actually branch. You get these sort of terminal branches, and it's called the terminal ductal lobular unit. This is actually where most of the action in the breast happens in terms of breast cancer and benign disease. So it's these little epithelial-lined structures here in the ducts, these epithelial tissue here, this is where the ductal cancers will grow from. And these epithelium lining out the lobules, this is where the lobular cancers will come from. But for some other reason, and we don't really know why, in some patients, there will be an obstruction that forms here in this sort of terminal interlobular ducts here. And that will cause the whole lobule to swell or just become filled up with fluid. And that is actually what a breast cyst is. A lot of these breast cysts, that little blockage that forms there will spontaneously go away. It often is just swelling that happens there. And the breast cyst will drain away on its own. So you'll see a lot of breast cysts. If you're going to send patients to a radiologist, a lot of the reports will come back. They've seen breast cysts. Or we tell the students that breast cysts are as common as freckles. You can go and catch 50 people here on Main Street. If they between the ages of 30 onwards and you're going to ultrasound all their breasts, you're going to find cysts in the breast. Doesn't mean that there's anything wrong. They happen in that age, and it's a sort of involutional process that causes blockages in those little ducts, which causes the cysts to form. They often present as a palpable lump and often with localized pain over that lump. And when patients are young, we do an ultrasound of that lump, and when they're older, we do a mammogram and ultrasound. This is a recurring theme. You'll see that's what we do for younger patients, ultrasound; for older patients, mammogram and ultrasound. This is what a cyst looks like on an ultrasound. It is a dark anechoic. There's no echo in it because it's fluid. It often has this posterior acoustic enhancement. It looks a little bit almost brighter behind the cyst. That is typical of a cyst. So when you see something like this, it's just black. There's just fluid inside. It's got a nice thin wall attached to it. This they would call a simple cyst. I'll show you another picture now. On mammogram, you see them as a density. Sometimes they've got a little halo around them on the mammogram. You can actually see that if you zoom into that cyst. But it can be difficult to distinguish between a fibrinoma and a cyst on a mammogram alone. But when you put the probe on, you will know which one is which. So a simple cyst, you can see this nice posterior acoustic enhancement here. It's anechoic. If it looks like this, the malignancy risk is exceedingly low. We don't do anything for them. We leave them alone. A simple cyst you can ignore. It's pretty much, you can tell the patient, don't worry about it. That is almost normal. You can ignore that cyst. It's not anything to worry about. If the patient came to you with a palpable lump that was painful, or there's a palpable lump, there's a big cyst there, you can put a needle in and you aspirate it. The fluid that comes out of it can be myriad of different colors, sort of brownish color, green color, sometimes sort of a CRC fluid can come out of it, a yellow fluid. So as long as it's not blood, you aspirate that cyst, you can feel it go away on your fingers. You throw away the fluid, and that's it. End of story. Patient is treated. You don't need to worry about it again, unless she comes to you again with a new cyst or whatever happens. So simple cysts, one doesn't need to do a lot for them. A complex cyst is this. On the ultrasound, you see a cyst that has got a cystic component. So there's a cyst there, but there's also something that looks solid. So that's called a complex cyst. So if they see any wall irregularity or any ingrowth into that cystic part, they will call it a complex cyst on radiology. They will often say BioRads3 follow-up, but complex cysts actually needs an ultrasound guided biopsy of the targeted to the solid component to exclude malignancy. The cancers that you get that present like this, they are sneaky and they're very, very difficult to diagnose. When you put a needle into that, it's very difficult to distinguish between a papilloma, which this sometimes often is, or between papillary DCIS or papillary cystic breast cancer. It's very, very difficult. You actually need to send that whole lesion to the pathologist before they can make that distinction. But a complex cyst needs a biopsy. They will report it as either a BioRads3 or a BioRads4. BioRads4 means the patient needs a biopsy. So nipple discharge. Nipple discharge could be physiological or it can be pathological. So I'm going to focus on the pathological nipple discharge. Pathological nipple discharge, if it's, you examine the patient, you look at the nipple, if it's coming out the same duct, so every time you squeeze, you see fluid coming out the same spot from that nipple. It doesn't come out from more than one duct. It comes out, there's about 15 milk ducts that opens up onto the back of the nipple. And it comes out the same duct all the time. It means that there's something sitting in that duct that's causing that secretion to happen. If it's blood, or sometimes what patients will tell you is there's lots of this watery fluid coming out of the duct. That's actually, I mean, that's how the papillomas, that's what they do. They produce this watery fluid. But it's usually spontaneous. So they'll see it on their clothes, they'll see it on their bra. The morning when they wake up after they slept at night, they'll see the fluid on their nightgown. That is how they usually present. It's unilateral, single duct, bloody often, or it can be copious clear secretions, and it is spontaneous. It's not with, pushing on that nipple. It comes out, they can see it on their clothes. That is pathological. Any other nipple discharge is not pathological, it's physiological. You don't need to do anything about it. Obviously, if it is milk coming out of the breast, that could be how a prolactinoma, for instance, can present. So for those ones, I might do a prolactin levels, but otherwise, it is physiological. And the physiological secretions looks exactly like the fluid that you aspirate from a cyst, because it comes from the same place. The fluid that's in a cyst is the fluid that's in a breast, and most women will have some secretions coming out their breast. Sometimes usually they're in the shower, in the bath, they wash themselves, there's some fluid coming out their breast. It's not a problem, they don't know about it. But if they go and they squeeze on the breast, and if you squeeze, you'll see some fluid coming out if you squeeze hard enough. Those are all physiological secretions. It often happens in patients with duct ectasia as they get older, that they lose elastin in the ducts behind the nipple. They get widened, and that accumulates secretions which will then present as a physiological discharge. The most common cause of these pathological nipple discharges is an intraductal papilloma. Here's an ultrasound of a papilloma. You can see the sort of ductal structure there. You can actually see how the duct sort of branches off there. This is what a dilated duct looks like on ultrasound. These things, usually you can see them, they are close to the nipple. So they lie just behind the nipple in that retroareolar tissue. That's where the papillomas occur. You don't usually see them further away. They're usually close to the nipple. So you see this dilated duct, and when you put the Doppler on, you can actually see blood flow inside, because sometimes you can get these sort of thick inspissated secretions inside these ducts. But if you put the Doppler on, it can look like this, but it won't have any blood flow. So there you can see it just side on. Again, there's some blood flow in it. This is what a papilloma would look like. You can do a biopsy on it. A papilloma or a papillary DCIS, it can look the same. This could be any one of the two, to be honest. But usually in pathological nipple discharge, 90% of the time, it's an intraductal papilloma causing this. DCIS, the problem is ductal carcinoma in situ. So this is cancer sitting inside the duct. It hasn't infiltrated into the surrounding tissue. It's not an infiltrative cancer. It can't, per definition, it can't spread elsewhere in the body, because the ducts and the lymphatics are sitting outside the ducts, the blood vessels. So it can't penetrate into a blood vessel and metastasize. It can't penetrate into a lymphatic and metastasize. DCIs are sitting inside the ducts, but they can present with a bloody nipple discharge. So this is why we do microdictectomies for these patients. So again, we would do a mammogram and an ultrasound. If the patient's older, they'll get a mammogram. If they're younger, they'll just get an ultrasound, or both of them. And if we see something, we will biopsy that. Some people do, I've put it in red because we don't do this. Some people do a cytology of the discharge. You can do it. The problem is, how accurate is it? If it comes back as normal, how are you going to reassure that patient and say there's nothing wrong with you? So this is the problem with cytology. You need to actually go and do a biopsy of that. If you think it's a proper pathological nipple discharge, you need to go and remove that duct with whatever is causing the discharge inside of the duct, so you can, and that's how you make the diagnosis. It's called a microductectomy. So I put a little suture down into the duct. I follow the suture. I actually injected a little bit of methylene blue into the duct so I can see which duct is the dilated duct. I remove that duct, and then hopefully inside of that duct comes out whatever is causing it. So the patient's discharge will go away, and I will also have a diagnosis, and I will know whether this is a cancer or whether this is a benign condition. Like I've said, most often it's benign. So we don't do cytology. I think the only benefit in cytology is if it comes back as they're seeing cancer cells there, maybe you will expedite the treatment for that patient. But other than that, I don't see any benefit. And actually, most of the breast units around the world that I have visited don't do cytology for nipple discharges. So breast infection. Breast abscesses are common, especially in lactating women. They occur because of Staphylococcus aureus. There's usually a crack in the nipple because of suckling. It often happens when the patients have their first child, and often happens early on when the baby is very, very small, when they don't latch on properly, or the patients don't know how to latch on that baby. It causes cracks, and bacteria can get in there. The breast is full of milk, which is lovely. Bacteria love it. It's food for bacteria, so it will grow like anything. And it's putting it into a petri dish in that breast. So Staphylococcus aureus will grow like wild in a breast that's full of milk. So the treatment of choice, because it is Staphylococcus aureus, is flucloxacillin. They usually are, these abscesses in lactating breast women are usually big. And, the treatment of them would be, as a first line, repeated aspiration. So you catch them early. This patient's lactating, there's redness there, it's tender. If you've got access to radiology or an ultrasound, you can put it on there. You can often see the abscess. They've got a very typical look to them. And when you put the ultrasound on an abscess, it looks like there's something moving inside. You can see these moving parts. That's the sort of thickened secretions inside those abscesses. When you see that, it looks almost like waterfall type of picture. That is an abscess. You can't really miss it if you've got access to an ultrasound. So the treatment, first choice would be repeated aspiration. But the thing is, you actually need to do it every 2 or 3 days. The problem is in the public sector, we can't do that. Our clinics doesn't run like that. So you need to see the patient often. You need to put a needle in. I usually use quite a big needle and I just aspirate it under ultrasound guidance, or if you can feel it and see it, you can get the needle into the abscess, you aspirate it. And you do that every 2 or 3 days while the patient's taking the antibiotics. And you can actually treat most of these breast abscesses with repeated aspirations. Problem is when they've been there for too long and they're so big that you actually almost have, looks like it's going to burst any moment. The skin is thin over the abscess. Those ones really need an incision and drainage. And actually the incision and drainage, the less you do, the better. You actually just make an open, you make a little stab there, you just wash the cavity out. And I will usually put a little pencil drain in there. So it just keeps the hole open for a couple of days while it all just collapses on itself, and they will heal like that. The non-lactating abscesses often are small. They unfortunately contain gram-negatives and anaerobes often, and are antibiotic of choice. You have to add flagyl if you're going to use Fluclox, or I just put them on Augmentin, on co-amoxiclav. You can treat them with repeated aspiration as well. They often are small, so what I would often do is in that initial inflammatory period, I would put them on antibiotics, let the cellulitis settle down, let the abscess sort of do what it needs to do. And then, when they are better, when you can touch the breast without them punching you, that's when I start either just doing a little lance in the rooms, or just aspirate that abscess a couple of times until it settles down. Problem with non-lactating breast abscesses, don't miss this. Or if you think there's a mastitis and that patient doesn't get better on antibiotics, don't miss an inflammatory breast cancer. So this patient, I took this picture 2 or 3 weeks ago. This is a patient that came to our clinic with an inflammatory breast cancer. Very, very, very difficult to diagnose. But if they don't get better on antibiotics, and it's an older woman, you need to think inflammatory breast cancer. And we've had lots of cancers presenting as an abscess. So in non-lactating breast abscesses, you actually do need to do a biopsy of that breast to just exclude that there's not cancer in that breast causing this. Periductal mastitis, I'm not going to say a lot about it, but it's very common. We see a lot of patients with periductal mastitis in our clinic. It usually occurs in heavy smokers. I mean, it's got 80% of these patients that come with periductal mastitis are heavy smokers. You know that they're heavy smokers because it's those patients that walk into your rooms and you can smell the cigarettes. Because the wait outside, that hour or 2 hour wait was too long. They had to go to the bathroom to have a cigarette in between. Those are the patients that usually have periductal mastitis. The patients that can't wait for 2 hours before they have their next smoke. You can smell them when they come in because they couldn't wait. Other patients would have had a smoke in the morning before they came to the doctor, so you can't really smell it on them. But those ones that have had one 30 minutes ago because they couldn't wait, those are the patients that often have periductal mastitis. It's more common in patients with obesity and also in patients with a late onset of menarche. Why, we don't really know. But the theory with this is, and smoking, not every patient is smoking. So the smoking, you can't always blame smoking. There is other things at play here as well. But the theory is, and we can see this often in biopsies. So patients that are, this is a normal duct. This is what it looks like. It's got a double layered cuboidal epithelium in it. So what happens in smoking, and the cotinine in the smoking causes a metaplasia of these epithelial line cells to a keratinizing squamous epithelium. It then secretes keratin, which plug the duct. The duct then swells up with secretions and sort of very, very thick inspissated secretions. It ruptures and then it causes an inflammatory reaction. So early on, it's this very, very painful, tender inflammatory reaction. It eventually would rupture onto the surface, and that will get my patient. They will immediately feel better when that happens. It will settle down, and they will eventually end up with a sort of chronically draining sinus on the edge of the nipple areolar complex. That's a mammary duct fistula, and that is periductal mastitis. If you catch it early, if it's acute, they might just have a little palpable lump like this. You can just drain that, you can lance it, give them antibiotics. I mean, we often give these patients antibiotics, but often it isn't if it's a new onset, if it's not a chronic condition. It's often not a bacterial or an infection. It is that sort of secretions that causes an inflammatory response in the breast. When it's a chronic condition like this, they often have secondary bacterial infection. If there's an abscess there, if it's big, you need to drain it. If it's small, sometimes you can just lance it. You need to encourage them to stop smoking. This is the biggest problem. Otherwise, it'll just happen again and again and again. And sometimes, we've taken some of these patients to go and excise all that sort of fibrotic tissue. And if patients continue to smoke, it's not that effective, to be honest. And 50% of them, it will just recur again. It's almost like a perianal fistula. There's lots of different, if there's lots of different techniques for an operation, it means that not one of those operations are very effective, to be honest. Then I'm almost finished. I know you're tired by now. Long day. So this is the last one, gynecomastia. It often occurs in patients under 20 or over 50. It could be because they're overweight. Patients overweight due to and that causes conversion of testosterone to estrogen in the fat, which can be a cause of gynecomastia. So when you examine these patients, you do the examination of males with suspected gynecomastia slightly different than when you examine a female patient with a breast. You get the patient to lie on their back. You use your thumb and forefinger, try and show you, like this. And you go from the outside and you work towards the nipple. If you feel this sort of round disc under the nipple areola, that's usually gynecomastia. If it's under 2 centimeter, it's considered within normal limits. If it's above 2 centimeter, it's gynecomastia. You need to do a proper general examination. Look for signs of hyperthyroidism. That can cause gynecomastia. Chronic liver disease, again, that's a cause of gynecomastia. Hypogonadism, so you need to examine their testicles and see if they don't have very small testicles. And you can measure their BMI, like I've said before. The patient can be overweight. And in some patients that are overweight, males that are overweight, they don't even actually have gynecomastia. They've got what we call pseudogynecomastia. It's actually just fat in that area, and it's not even glandular tissue. So I just feel, especially in younger males, you need to do a testicular examination. And we usually would do a testicular examination. You can look at the testicles, you can see if the testicles are very small, and you can check if there's any masses that might suggest a testicular cancer. Gynecomastia is usually bilateral, but it can be unilateral, and one needs to be careful with patients with unilateral gynecomastia, especially if they are older. So we would biopsy patients with gynecomastia if it's unilateral, especially if it's older patients or if they've got a family history of breast cancer. Be very, very careful of doing fine needle aspirations of gynecomastia. We've had them. I stopped doing it altogether. We've actually stopped doing fine needle aspirations in our clinic completely. We don't do them anymore. But in males, we've had more than once where it was called a breast cancer on fine needle aspiration. It looks different than what the cytologists are used to when you send them a fine needle aspiration from a female. And yeah, they overcall it. They'll call it a cancer, and it's not. So we prefer to do core biopsies on these patients if we suspect that it might be a cancer. Usually the cancers don't look and feel like gynecomastia. It doesn't have that feel. There's something wrong. You often see puckering of the skin, nipple pulled in. They look different, and they've got all some same symptoms and signs that females have got. They might have enlarged nodes, but they do not feel like that disc-like, quite symmetrical, right behind the nipple enlargement. They don't have that. They look different. So the cause is essentially anything that gives you a low testosterone or a high estrogen level. And I try and stay away from doing too many blood tests on these patients because actually, at the end of the day, we don't really do anything if they're asymptomatic. So if you want to do a blood test, you can do baseline blood test, which will include a thyroid function test to exclude hyperthyroidism. If they've got a normal pulse rate, then they probably don't have that, but one can do that. Again, it costs money. The UNE will exclude renal disease, and liver functions will exclude liver cirrhosis and things like that, liver conditions. If these tests are all normal, you can consider a hormone blood screen, which would be a testosterone level, an LH level, beta HCG, alpha fetoprotein, prolactin, and serum DHEA. And these are to look for a number of conditions. It is completely normal in a lot of times. I mean, it's actually, when you look at the literature, they say only about 5% of time are you going to really pick up something. So you're going to spend a lot of money to pick up rare diseases. But if the testosterone is low and elevated LH, you must think of primary hypergonadism or Klinefelter syndrome. If they've got a low testosterone with a normal LH, think of pituitary or hypothalamic disease, because that LH is not responding to the low testosterone level. Serum DHEA level would point to an adrenal tumor. Elevated beta HCG to a testicular or ectopic tumor, and elevated prolactin level, look for pituitary tumor or drug causes. The drugs, you need to take a very good drug history in patients with gynecomastia. You must ask them whether they're using, often they go to the gym, they're using all sorts of supplements that can cause gynecomastia. They often use steroids. Ask them if they're using steroids. If they just look like they're going to the gym and they're pumping up a bit, they often inject themselves with steroids. And I've heard of people selling steroids and then also giving the patients tamoxifen to counteract this, to prevent the gynecomastia. So ask them about steroid use. The other common drugs is digoxin, spironolactone, and cimetidine that can give that. And then when in drug-induced gynecomastia, the offending agent should be withdrawn. In patients with physiological gynecomastia, which is these younger patients, adolescent boys, reassurance, and 90% of them will resolve within 3 years. For those who remain a problem, so if they've got pain, I've used tamoxifen. The nice thing about tamoxifen in men, it's got no side effects. So you can give that to them, they've got no side effects, and it can relieve their pain. I've got a patient that chases me around the hospital. I see him every couple of months, and then he wants more tamoxifen for his gynecomastia because it's painful. And he says it works for him. So I sometimes use that. Again, it's an unlicensed use. And if you really want to take it away, if it's a problem, it's going to be either liposuction or subcutaneous mastectomy. Problem is the medical aids don't pay for this. So they get sent to Groote Schuur. Groote Schuur do very few of them. We don't do them. I send them to the plastic surgeons. So we don't do them. I don't have theatre time to do benign conditions really like this. So they usually go to the plastic surgeons to have a subcutaneous mastectomy done. So we often, people get referred in with medical aids because the medical aids don't want to pay for it. And then it's also not done in the public sector really. So, but if they do have, sometimes you get boys with really big breasts, big cup-sized breasts. Obviously, that's a problem, and plastic surgeons is not against operating on those patients and actually doing removing that breast tissue. So I just wanted to go lastly through the criteria for referral to us. The presence of a discrete lump is always an indication for a referral, except in a patient that is a teenager under 20. A lump we don't see in our clinic. Persistent non-cyclical asymmetric nodularity, that needs referral. Spontaneous single duct nipple discharge, a pathological nipple discharge, needs referral. If it's blood stained, needs referral. Mastitis not responding to antibiotics, needs referral. Breast abscess needs referral. If it needs drainage, it needs to be done in theatre. It needs referral to someone who can do that. Inflammation or ulceration of the nipple areola complex. This is really for patients with Paget's disease. They usually present with an ulceration of the nipple itself, which is different from eczema, which sort of affects not the nipple itself, but rather the sort of areola more than the nipple. It's also not uncommon to see patients with eczema, but most of them will respond to steroids. And any new onset nipple retraction or inversion needs to be referred. So with that, I'll thank you. And then I just want to say a couple of words. So at the Groote Schuur Breast Clinic, we've got a website called GSH-breastandendocrine.co.za. best is if you don't Google breast clinic, but rather type that into your Google browser, and then it should take you to that website. So you can then click on appointment at our clinics, or you can click on I just want to refer a patient for a mammogram, and you fill in your details, you fill in the patient's details. It will ask for some symptoms. It usually will prioritize patients according to the symptoms, and try and be as honest as possible with that symptoms, because if you send a patient and that symptom is not really the symptoms, you're going to take a spot away from someone who's got an urgent symptom. So the system will automatically sort of prioritize patients. But essentially, we see patients at the moment, no patient waits longer than 2 weeks to get into the breast clinic. So it's a 2-week rule. If it's good enough for the NHS, it's good enough for Groote Schuur Hospital. So it's not a walk-in service anymore. Patients need an appointment. We will see them within 2 weeks. That is the guidelines that is used in the NHS. Any patient with a breast symptom that needs referral need to be seen within 2 weeks, and we try and stick to that as much as possible. We might go 1 or 2 days over that time, but they don't really wait longer than 2 weeks. So please make use of that. There is an app on the Play Store as well now for Android devices. You can just search for it under GSH Breast and Endocrine Clinic. So our surgical thyroid clinic and sarcoma clinic can also take bookings via this website. It's not just for the breast clinic. So if you've got someone with a big thyroid or a thyroid nodule or a thyroid problem, you can use that website to book straight from the website as well. And when I designed this website, I mean, my main thing was I don't want the patient to leave the doctor's rooms without an appointment. That patient needs to have an appointment when they leave, because otherwise it's difficult for the doctors to now phone patients back again later because they can't get appointments. You phone Groote Schuur, no one answers the telephone for hours on end. So you can go online, you will fill in, a calendar will come up. You choose a date, you choose a time, you click submit. You will immediately get an email back saying your patient's been accepted, or you'll take you to a new screen saying your patient's been accepted. You can send the patient, their name is on a list, and they will be seen. And then at Ingress, you can, if you've got patients you want to refer to us on the private side, you can either search my name, it should pop up. You can go to the website ingresshealthcare.co.za. You can book it from there. You can just send a WhatsApp saying, I want to make a booking with Francois Malherbe or Tertia van Wijngaard, and someone will come back to you and say, okay, this is, give me the name and I'll book the patient for you. We see patients quickly. They don't have a long wait. Between me and Tertia, we would see a patient with a breast complaint usually within a day or two. So with that, I will thank you. And yeah, I don't know, Jason, is there something you want to say? Something I must click?
I'm good. Thank you very much for an excellent talk. We appreciate everybody's time. And as I said in the comments, we will follow up with CPD points via email with everybody. But do check in. We will be hosting CPD point events and webinars for both breast and general surgery, as well as other disciplines in the coming months.
Yeah, so I don't know if there's a Q&A stuff. Has Tertia answered most of the things, it looks like?
I've answered most questions.
Otherwise, I can stick around
for 2 or 3 minutes. If anybody wants to just type further questions, we will hang around for a while and respond.
And I don't know whether people had put down anything that we can do further talks on. Tertia will know that. But if you guys can please, if there's common general surgical topics that you want us to give a talk on, I mean, I will follow up on these talks as well. I will do some more talks on breast cancers and other breast conditions. So there will be follow-up talks. But if you want general surgical talks, make contact with me, send an email, and we can organize that. We will definitely try and do some more talks. Okay.
So maybe, Francois, if you want to maybe, you can stop your video and audio, and let's just hang around to reply to any written messages. But everybody, otherwise, thank you very much, and we hope to see you all again soon.